Hi there, I'm Dr. Richard Finn from the Geffen School of Medicine at UCLA. I'm a medical oncologist, and welcome to this Preciska GI tumor board. I am joined today by a very esteemed faculty, and I'll start with introductions. Dr. Catenacci.
Hello, I'm Dan Catenacci. I'm a GI medical oncologist and director of the GI oncology program at the University of Chicago.
Hi, I'm Marty Weiser. I'm a surgical oncologist at Memorial Sloan Kettering Cancer Center in New York City.
Hi, I'm Darren Keyes. I'm both a interventional and diagnostic radiologist at the Piedmont South Imaging Center, covering 2 hospitals southwest of Atlanta.
Hi, I'm Pritesh Patel, a radiation oncologist focusing on GI malignancies at Emory University in Atlanta.
This is a 46-year-old gentleman with symptoms for 1 year and a workup which revealed an adenocarcinoma of the distal esophageal gastroesophageal junction and gastric cardia. The tumor is HER2 negative with imaging revealing lymph nodes in the celiac lesser curvature and gastrohepatic region. Endoscopic ultrasound is performed, and this reveals extension beyond the adventitial, and it's staged 4A. That's clinical T3 N2 M0. So the question for us to address today is surgery an option for this patient after neoadjuvant therapy? And should FLOT for chemotherapy regimen be offered or chemoradiation followed by surgery? So here are a few more details on the patient. Presented with 1 year history of worsening abdominal pain, nausea, fatigue, weight loss of about 50 pounds over 3 to 4 months, intermittent dysphagia and decreasing appetite. The ECOG performance status is 1. Otherwise, as far as past medical history, this is a very healthy patient. He does have a significant smoking history of 20 pack years, doesn't smoke or drink, works as a manager at a fast food restaurant, is married with 3 children. As far as family history, they had a maternal uncle with brain cancer. So the report on the imaging from the chest from April of 2021, this is chest, abdomen, pelvis. There's marked mass-like wall thickening of the distal esophagus, several sub-centimeter periesophageal lymph nodes in the chest and around the thickened esophagus. There's a distal esophageal mass with likely extension to involve the gastroesophageal junction and cardia. There's intradiaphragmatic and local regional adenopathy measuring up to 3.8 centimeters and soft tissue along the celiac axis gastric artery that may conglomerate nodal disease and or extraluminal spread. The endoscopic ultrasound is performed, and this reveals partial obstruction, likely malignant esophageal tumor in the distal esophagus, which we now know is adenocarcinoma. It's extremely friable with contract bleeding. So an EUS is done, partial obstruction, likely malignant tumor in the distal esophagus, extremely friable with contract bleeding. The mass was 37 centimeters from the incisors, partially circumferential, involving 2/3 of the lumen circumference. The tumor disrupts and extends beyond the adventitial layer, and there were many malignant appearing lymph nodes visualized in the celiac region. So here we have some imaging, and Dr. Keyes, maybe you could take us through that.
Absolutely. So there's several images on the left side of the screen, and these are just pictures from an endoscopy, which clearly show there's a large friable mass. You can see there's pinpoint areas of bleeding. It's kind of fungating appearing. These findings are consistent, with an adenocarcinoma in the esophagus. There's some other images that show kind of a more normal appearance of the gastric lumen once they get beyond the tumor. The images on the right side of the screen are actually endoscopic ultrasound images, it shows that there's a mass associated with the wall of the esophagus. It's a little hard to tell given the small size, but presumably that mass, you can see the borders are quite lobulated, and it likely extends beyond the adventitia of the esophagus. Image number 4, I think, and 5 clearly show a nice example of what an enlarged malignant appearing lymph node looks like under endoscopy. When an ultrasound gets that close to something, it shows the architectural detail very well, and you can actually see the needle when they did a fine needle aspiration in image 5 going directly into that malignant appearing node. And then images 6 and 7 show some smaller lymph nodes in that region.
So a PET CT is done, which reveals this mass that was described on endoscopy, 5 by 2.5 centimeters. It extends approximately 6.2 centimeters from the GE junction to the cardiac portion of the stomach. So fairly locally advanced tumor. And also at the level of the lesser curvature, there's approximately 4.7 centimeters lighting up a nodal mass on the PET CT, as well as a few gastrohepatic lymph nodes, scattered periceliac lymph nodes, and aorto-caval lymph nodes, sub-centimeter lymph nodes. And here we have the PET CT. Do you want to comment on this as well?
Sure. So we've got 4 axial images, and these are fused images showing both the PET and the CT together. And then on the right, there's a coronal image. The images show that there's a circumferential, intensely FDG avid mass involving the distal esophagus, the gastroesophageal junction with extension into the gastric cardia. The 4th image, the bottom right image of the axial images, actually shows that lymph node conglomerate that's sitting right above the celiac axis. And if you look on the coronal images, you can see the dominant mass is kind of the superior FDG avid lesion, and just below it, you see a very FDG avid lymph node mass, in the supraceliac region. And these findings are all, consistent with the esophageal adenocarcinoma and a lymph node metastasis.
So this kind of brings us to the clinical decision making, and in summary, this is a fairly young, healthy gentleman who's presenting with fairly locally advanced gastroesophageal cancer, GE junction cancer, an adenocarcinoma that's HER2 negative. And the questions laid out for us is, one, is surgery an option for this patient after neoadjuvant therapy? And then what should that chemo or chemoradiation regimen look like? And there's obviously been a lot of data that's been advanced in the fairly recent year or so that will help inform us. So, maybe I will first call on Dr. Weiss to give us his input about, is this patient a surgical candidate? Are they curable?
Well, there's no doubt this is quite locally advanced, and there is significant lymph node disease. However, if the aortocaval nodal disease is not real and the FDG avidity is not very high, then the other basins would be included in the usual 2-field lymphadenectomy that would be performed for this CWER 2 or 3 esophageal cancer. So I do not see an absolute contraindication to surgery in a young, healthy patient. Now, of course, that would be different if the patient were infirm, elderly, in which we may not want to embark on surgery. The surgical approach, of course, would probably be a thoracic and an abdominal approach, an Ivor-Lewis approach. But the other options would include a transhiatal, less common in this situation, or a 3-incision esophagectomy. So to summarize, I would not rule out surgery in this healthy young patient, albeit I would make him stop smoking.
So the question is now, and an area of, I think, some debate between how we manage this patient in the perioperative setting. So certainly there's the opinion that chemoradiation preoperative is the standard versus now evolving data from several pivotal studies that have read out about the role of just chemotherapy up front. So we'll start maybe with you, Dr. Catenacci. What's your take on the perioperative management for this patient?
Sure. I would also echo Dr. Weiser that, we would be really looking at that periaortic lymph node as with concern more as an M1 lymph node and more systemic disease here at this point. And frankly, even if not, the celiac plexus there really sort of suggests that this is advanced and yes, localized, locally advanced, but also has a really high risk of metastatic disease recurrence over time. And so the other thing that we might do here, we probably would do before getting and embarking on therapy, is we would do a diagnostic laparoscopy to evaluate what's going on there. If there's any macroscopic disease, certainly but also do peritoneal washings. Because these tumors, especially the ones that get into the cardia, they have no disease positive, they have a high risk of occult peritoneal disease, which would be important to know before we even get started if that is or is not present. So assuming that was not present and this procedure was done, then our institution, at least, and as you pointed out, there may be more than one way to address this issue, but our institution, given all of that and taking all of that into account, we would start with systemic therapy, potent systemic therapy with FLOT or a clinical trial, of course. We've been using also FOLFIRINOX on a study to try and address and mitigate this risk of distant micrometastatic disease and also downstaging of the primary tumor. Most patients, their dysphagia improves within the first 1 or 2 cycles of that therapy. And then we would usually treat with 4 cycles and then reassess with CAT scan and PET scan, and then bring it back to multidisciplinary tumor board to evaluate if there has been a response and if the patient can then go to surgery, or if there's not been response, maybe then we would consider adding in a chemoradiation component as long as there's not distant metastatic disease in that situation. So that's typically how we would approach this particular case here.
So just so I could summarize, your approach would be a diagnostic laparoscopy to further stage the aortocaval node, because that's an important decision point, whether this is overt metastatic or just locally advanced, and then maybe favor systemic chemotherapy for a few cycles and reassess.
That's right.
And so obviously radiation oncology plays a big role in these patients as well. Dr. Patel, how about your take?
Yeah, I agree really with the excellent points that have already been made. I think screening for metastatic disease with the diagnostic lab is also something that we would typically do first. Maybe another point to bring up is this patient's lost 50 pounds, and do we need to maybe consider nutrition, and that could be something maybe we think about beforehand. Our institutional practice is typically also to use neoadjuvant or perioperative chemotherapy in the CWORD 3s. In the CWORD 1s and 2s, we still consider chemoradiation as the upfront treatment. So if all of the rest of our workup is negative in terms of any risk of micrometastatic disease, and certainly that periaortic lymph node is concerning, in that situation, for a CWORD 1 or 2, we do consider chemoradiation, and then for the CWORD 3s, typically perioperative chemotherapy. And I might add, we've made some progress, I think, in what we're able to do now with chemoradiation. I'm fortunate to work at a center with a proton therapy unit, so this would be a case where we would almost certainly consider treatment using proton therapy, which, given the location of this tumor immediately behind the heart, in a patient who's still actively smoking, I think could make a difference in terms of the toxicity with just during treatment, and then the perioperative mortality as well, or morbidity, as we saw in the randomized MD Anderson study of proton therapy. So, but I agree. Really, both options would be considered standard. I know we have randomized evidence now that seems to show similar outcomes.
Okay, well, I think that is a pretty state-of-the-art discussion for this patient. I think personally, I'm concerned that this patient has fairly advanced, locally advanced, right? This patient's at very high risk for systemic recurrence. And I think from the tumor board, we would concur that I agree smoking cessation is important. Addressing their nutrition status is critical, right? You bring up an excellent point, Dr. Patel, and whether they need a feeding tube or some other nutrition evaluation to help support them through the next stage. An XLAP, I think, would be recommended to definitively stage this patient. And I think it's fair to say that upfront systemic chemotherapy with FLOT for 4 cycles and reassessing would be appropriate. If there's excellent radiation oncology expertise, I think, at the center, perhaps chemoradiation. But I think there's a little bias in this specific patient because of the extensive disease, maybe for systemic chemo upfront. I think that is a fair assessment.